and I'm going to share my screen now. Amazing. So as we discussed, guys, we're discussing today sensory processing in adults, interventions and assessment. My name is Nav Singh, and I'm an occupational therapist. I am very blessed that I am able to practice in regional township of Ararat. And we get heaps of referrals from supported independent living options, from SDAs, from hospitals, and schools to do a lot of these assessments for their participants. And it's really lovely to work in the region. So just a little bit of session outline. So we're going to be discussing today what is sensory processing, what is sensory processing disorder, what's its prevalence, what are the causes, types of sensory processing disorders, and then what assessments we do. And then I'll also share with you some sample assessments that we've been doing here at Country Therapy. So what is sensory processing? Well, it is also known as sensory integration. So first defined by Jeans Ayres in 1972 as the neurological process that organizes the sensation from one's own body and from the environment and makes it possible to use the body effectively within the environment. So to simplify this idea as to what is sensory processing, what is the disorder going, I thought I'll create this little diagram and sort of, run you guys through it. So on your left-hand side, you see that there's the brain, which all of us have, hopefully, and we've got different sensations. So we've got taste sensation, we've got touch, smell, sound, sight, movement, and balance. So all of us know generally that taste, touch, smell, sound, and sight are the 5 sensations, but a lot of time people sort of don't realize that movement and balance is also a very important part of our sensory systems, which often, gets underlooked. And then all these sensory systems capture different sensory information based on their expertise. So the taste center, the balance center, all these different centers, they receive this information, they process it, and then pass it to the brain for further processing and making sense of it. And then the brain gets these sensations, sort of understands what does these sensations mean, and then generate an idea that, okay, looks like based on the information that we're receiving, this is what we need to do, or that is how we need to act, or this is what we're going to do to respond to this situation. So it's very interesting, how all of these different sensory systems, really ensure that an idea, a concept, or, a presentation is, the outcome. On the right-hand side, you would see it's the same thing, the brain, but this is where you can notice the disorder. So over here, the taste, you can see that there's a normal error. So that means the brain's receiving normal taste response. But here the touch response seems a little bit more stronger. Smells going as it should be, movements going as it should be, but then there's no sound, sight, or balance response. So the brain's getting very limited information to process through the sensory systems as to what's going on. So the brain's not going to understand a clear picture as to in what scenario is this individual in right now. So it's going to act based on the information that it's receiving really clearly or really precisely. And then it's going to generate idea on what needs to be done based on that limited information that the brain has. So that's where we start seeing sensory processing disorder. That is where the trouble sits. And, when we're going to talk more about different types of sensory processing disorder, keep this in mind, these 2 concepts, because that's going to start making a lot of sense for all of us. Now, before I proceed, I'll just double check if there's no not a lot of people waiting on the waiting list. Alrighty, fantastic. So, what is the prevalence? How many people do have generally get the sensory processing issues? So, 1 in every 6 children tend to get a diagnosis or an underlying diagnosis of sensory processing disorder. It is, this broad spectrum of the severity. It impacts different individuals or children with, most commonly diagnosed in children, however, often persists into adolescence or goes undiagnosed into adulthood. So it is very, very common. 1 in 6 is a big number. Common associated symptoms: anxiety, panic disorder, depression, PTSD, schizophrenia, autism spectrum. Up to 95% of individuals who are on the spectrum generally, have sensory processing disorder. Then developmental disorders and neurological conditions. What are the causes? Well, the preliminary research suggests that sensory processing disorder is often inherited. It's quite surprising, but that's what the research is suggesting right now. Prenatal and birth complications can also be a big contributor to sensory processing disorders. Environmental factors, damage in any part of the brain involved in multisensory processing. These could be all part of the causes. Now, types of sensory processing disorder. So we've got sensory modulation disorder, we've got sensory-based motor disorders, and we've got sensory discrimination disorder. So we're going to go into a little bit of depth into all of these specific disorders, one thing at a time. So sensory modulation disorder. So our complex central nervous system processes by which neural messages that convey information about the intensity, frequency, duration, complexity, and novelty of sensory stimuli are adjusted. So this is where we see that there are some challenges that happens under sensory modulation disorder. So it consists of 3 subtypes, which is sensory overresponsivity, which is like that you get exaggerated negative response to sensory input, often leading to avoidance and hypervigilance of stimuli. There's a lot of times I hear parents say, oh, my child's got ODD. Oh, my child's got, he's a bit defiant. So often, Google is a big contributor to this misinformation, because parents would just write down these, oh, my kid's doing this, and they'll get this terms and they'll start throwing it around. But understanding a good clinical picture is very important, because often children who are sensory overresponsive can seem like they're quite negative and that they're trying to avoid a lot of situations. Doesn't mean that they've got ODD and things like that. So a good clinical picture is very important. Sensory underresponsivity, which means that individuals may seem unaware of or slow to respond to a stimuli that would typically be expected to elicit a response. Often I get a panic call from parents. Mums would be calling me. They're like, oh my God, the school saw these bruise marks on my child. They were asking me, am I going to be in trouble? Are they going to call child protection? And we're going to really walk them through it that, because your child's got a very high threshold to pain sensation, they generally end up bruised, but it doesn't really mean that there's anything going on. So don't stress about it. Obviously, we do comprehensively communicate with the family. We do communicate with the child. We do analyze and assess their environment to ensure that there isn't something else going on. But a lot of the times you'll see kids who've got a sensory modulation disorder who are under responsive with a lot of bruises. sensory craving or seeking behavior, when an individual has an unusual craving for or preoccupation with certain sensory experiences. So one of the examples that comes right to my mind is that there is this individual who we work with, and when he gets distressed or isn't feeling regulated, they start immediately picking anything from their environment and start chewing on it, be it any object, cement, cotton, fabric, anything they can get a hand on, they'll start chewing. So that's the extreme bit of it, but that's where you see that there is a bit of a seeking and craving behavior. Then we've got sensory-based motor disorder, which is motor challenge with underlying sensory basis. So unlike sensory modulation disorder, where individuals have difficulty regulating sensory input, individuals are regulated but have a sensory motor challenge. So they seem very regulated, but they've got a sensory motor challenge. So the subtypes could be dyspraxia or postural disorder. So for example, you will see somebody walking with an extreme stupor, walking really bent over, and you don't find any musculoskeletal issues. There's nothing wrong with the spine. What could it be? You can see that there is, that person's on autism. They've got, these other challenges, and that's where you can realize that, okay, it could be a sensory motor challenge as well, which is always great to be assessed. Often, sometimes we do if we do identify a sensory motor challenge, we would collaborate with physiotherapists or chiropractors and then have a much more multi-team integrated sensory plan to support individuals. We've also got the last one, which is sensory discrimination disorder. Now, this is where a person is not able to discriminate each individual sensation clearly, and then they're sort of seeking or missing on different sensations all the time. So it could be visual, taste, smell, auditory, touch, vestibular, which is, how are they positioned in the environment, proprioceptive or interoceptive. So sensory discrimination disorder is generally a lot of the times people can pick in children, because you'll see that they're displaying an array of different disorders, array of different challenges. Like for example, you go to a house, you see a child really staring at pictures, and the next thing he's doing is getting up, he's jumping on furniture, he's fighting for mom's phone or dad's cell phone, fighting for iPad, screaming suddenly, touching, no body awareness. So that's where you see that there's an involved array of sensory discrimination disorder and a child who's struggling with those sensations. There's a few assessments as occupational therapists that we do. These are the ones that I prefer to do. So one of them is adolescent adult sensory profile, which I will show you briefly what it looks like. And it's a really good assessment. It gives you a good picture of, what their sensory systems are like, and helps you clearly identify what sort of a sensory processing disorder this person's got, and what can we offer them to, better regulate themselves. For children, from 3 years up to 13, we use child sensory profile assessment. And that again, gives you a really good picture as to where on the spectrum of sensory processing is the child sitting, and what can we do to help them better regulate, or what changes can we do. And I've got a sample assessment that I've done, and I'm more than happy to show it to you during the presentation. And then the last one is school companion sensory profile 2, which is more specific to a child's need in the school environment. The teacher generally fills this questionnaire for us and gives us a bit of an indication as to what they think has been happening in the classroom. Obviously, you're going to mix it with your own observations, because a standardized tool is not everything. So the observations go hand in hand. And then that helps us better understand as to what's going on and how we can better help them. So I'm going to now move to showing you the sample assessments that we do, and then we can probably move on to some questions. So bear with me 1 second. So I'm going to share my screen now and show you what a child's sensory profile looks like. So this is a child sensory profile for years 3 up until 14 years, 11 months. It is predominantly filled by a caregiver. And the questions that we ask in this questionnaire are pretty much like, do you see this behavior? What represents with the opportunity? What do you think your child does this? Does he do it always, almost always, frequently, half the time, occasionally, or almost never, or that it does not apply? These are the set of questions. So for example, under auditory processing, we would ask questions like, do you think your child reacts strongly to unexpected or loud noises? Example, sirens, dog barking, hairdryer, and then we get a score here. And similarly, we get scores for visual processing, we get scores for touch, movement, body, oral sensory. We do know that kids often on the spectrum have a lot of oral sensory needs. So we do that. Conduct associated with sensory processing, social emotional responses associated with sensory processing, and attentional responses. Once we've got the raw scores from parents, we transfer that onto this grid over here, and then we analyze it and then see where is that child going to fit on this profile. Say this center, if a child has scored a score between these numbers, that means they are regulating just like any other child their age. But if it is a number between 7 or 19, 0 or 6, then we know that, okay, they are not regulating at the same piece the same age. They are much less, or lesser than others, or much lesser than others, and same things that they're on the higher side of this sensory processing challenge, and they do react more strongly or much more strongly. So that's the child sensory profile. Now I'll share with you the adolescent adult sensory profile. It's pretty much the same, just like the child questionnaire. So this is what that looks like. It's a self questionnaire, but sometimes we can get feedback from the caregivers. The instructions the same. How often, are what do you think, is this person mostly reacting to? Like, are the scores between almost never, seldom, occasionally, frequently, or almost always? So, for example, because it's a self questionnaire, you got to change it. If the person's not able to answer themselves, and if the caregiver's answering, you would say, do you think the person often leave or move to another section when they smell a strong odor in a store? For example, like a bath product, candle, they just don't want to go there. They want to move to another place and be there. And if the answer is like, oh yeah, they almost always do it, then you take yeah. And, again, the answers sort of vary. And then it goes on and all. It's not as comprehensive as the child one, but it almost comes up to auditory processing. And then we do the same thing. We fill up the grid, get the raw scores, and then we see, okay, how are they responding? And this is sort of like the box in which they would fit in once we've got the classification. And then the last one that I would love to show you would be the school companion profile. So this is what the school companion sensory profile tool looks like. It is for ages 3 to, again, 14 to 11 months, which is roughly 15 E's, again, completed by the teacher. And, we put in what school, what grade. We ask them questions like, do you think the child misses verbal directions in class more than the same age children? And they respond accordingly, react strongly to unexpected or loud noises. Visual processing wise, is there a challenge there? Touch processing wise, do you think, does the child displays a need to touch objects? So it goes on and on up until behavioral responses. And then again, we score it, and then we see where is the child sitting in the quadrants and the grids. And then is the child's score consistent to what other P's his same age should be like, or is it on the more side, or is it on the less side? Now, any questions so far, team? I can see there are no hands raised. There's nothing in the chat box. So I'm just going to move on to um, showing you some samples of assessments that we've completed. And obviously, we've taken away the names and things, but alrighty. So this is occupational therapy sensory profile report that we've completed for, one of our kids. We just give a few bit of background information there. And then there is, obviously the responses. It's just to make the reader understand. Often NDIS planners, aren't aware exactly what the scores mean, what this means, what that means. So it's just something to, sort of help them better understand what the scores mean. Now over here, this child pretty much was on the much more spectrum of sensory seeking. The child was also an active avoider. They were quite sensitive, and registration also was a bit of a challenge. So we write here the parents' names, and that, okay, this is what what the scores obtained from them, and that this child seeks sensory input much more than others, which suggests that she requires much more sensory stimulation to that of P's her age to feel regulated. We put in some more details in there, and again, it goes across all the different quadrants of sensory processing as to what this child's facing really challenges in. This is the behavioral section, which I think a lot of times behavior support practitioners, psychologists, and even teachers, or SDA providers look for. They want to see how much of their conduct, social emotional responses, or attentional responses are associated with sensory processing challenges. And when they see that this is where children are sitting in, they just know that, okay, well, they're just not like majority of others, and they've got all these issues. So it starts making more sense to them that, okay, their conduct could be an issue because of their sensory challenges across these areas and whatnot. Then we explain to them that what does this means. We give a general picture of what this profile aim to do. What does the patterns and the profile means? There is no good or bad sensory processing preference. Seeking, this describes people with higher neurological threshold who actively try to self-regulate to meet their needs. So a child with more than seeking pattern score has a high threshold for sensory input, and therefore may seek additional sensory input and need sensory experiences in their daily routines. So we give some based on the sensory profile. This is how they're seeking: touching people, staring at people, walking across, need to touch toys. What this means for this person is that they're trying to seek additional sensory input. So to assist them in avoiding these behaviors, they can benefit by doing these things, and we then list out some strategies for them to replace their behavior. Like, it's not really good for a child or for an adult to go and touch other people, not know their boundaries, know what are the social norms, and walk into other people's personal space. So it's really good to make these suggestions so that whoever's caring for them, be it parent or for an adult, if it's a caregiver, they understand that, okay, we can replace those behaviors with these things. And the list goes on and on. So generally a sensory process. We also make recommendations for the school. Now, NDIS is not very happy for us to make recommendations for school because they often think that's Department of Education's responsibility. But then as clinicians, we try not bend to the bureaucracy, and we do make suggestions for school because at the end of the day, it does help a child better build capacity towards a number of the NDIS goals. So, and teachers are really happy when they receive these sort of, some simple suggestions. And we also provide them with some more suggestions for home, what they can do. And again, as I said, the list goes on, and almost 15 pages. So that is for the child sensory profile assessment. Now I'll show you what an adult looks like. It looks very different to this, and the recommendations are also quite different. Now, again, it depends from different practice, from what practice the referral has come from, or what clinic you're working with. So in our practice, this is how we sort of tend to create. Let me share my screen. So this is for an adolescent sensory profile. So again, we lay out the reason for referral. It's very important for the NDIS to understand why we are doing things. Medical history, behavioral output, very, very important, because often we can then link the behaviors to what parts of it is sensory. And it, as I said, it helps the psychologists, the behavior support practitioners with their work as well. It's just more evidence-based. We get details from support workers and, what have they been doing, what observations we made, what interests they have. And then this is where the profile comes in. And we explain to them what and how to understand this questionnaires outcome. For example, this person had more than most people score for low registration, much less than most people in seeking behavior. This person was just like others when it came to sensitivity, as to how much sensitive they are to sensory stimulation. And then they also, when it came to sensation avoiding, this person was able to score much more than most people. So then again, we go into describing that what's the summary, what the quadrant scores means. That this person is just like most of the people in sensory sensitivity. However, this person scored more than most people in these two areas, and that this person scored much less than most people in seeking quadrant. And then, so how do you explain that? So, for example, individuals with low registration tend to miss or take longer to respond to stimuli that others notice. So often you would hear feedback from SDA saying, oh, well, we can scream his name, but he doesn't respond unless we go and, tap him or something. And it could be because the person, and his hearing's fine. So we'll be like, well, it could be because the person has low registration and, they might not be able to register your information very quickly. So maybe if you repeat it loudly enough, close to them, and give them a pause to process that information and then respond, often you would see that they will respond. And people have tried it and they've been quite surprised. They're like, so he can register. And be like, yes, they can. So things like that. Again, it goes in depth. I wouldn't go into all bits of it, but when you read the sensory assessment, it starts to make a lot of sense, especially for the care staff who are there regularly. And then this is where the quadrant sits. So again, this middle equal is where most people should sit. And then this person has, obviously 1+ means more than most people, 2- means much less than most people. Equal means they're just like, their aged peers. And here it means more than most people. And then we present our interpretation, quadrant interpretation, and then obviously we give a summary, and then we explain that, what could be the challenges that you're seeing, and then make some recommendations. So here we've made a recommendation to start developing a sensory toolbox so that, that person, when he tries to generate, his own stimulation by doing things that is not acceptable in the household that he's living, and reducing his capacity, then that sensory toolbox can be a bit of a behavior replacement strategy where, okay, well, how about you use this instead of that, and start grading it down to something that is more acceptable. And then it goes on and on. And then over here, we've also made suggestions. So this is sensory environmental checklist as to what we can do to, so this is a sensory support plan, and by ticking this, by with our observations, with the outcome of the assessment, we guide that, okay, well, this person doesn't like bright lights. He would be much calmer if there are if he's outside in the nature. This person does not like a lot of people moving around them. They would be much more calm if there's a TV or movie going around in the background. Or this person does not like a lot of things on the walls, like curtains and things. They do prefer bare walls. And this, a lot of people who are transitioning from their house to a supported accommodation or to a supported independent living or to an independent living option, it's always good to provide this sensory support plan so that the housing provider can, help them, with their choices or with the type of housing and things like that, that can really help them in the long run. So that's the adult assessment. Now I'm going to stop this presentation and we're up for questions, guys. And Karen, feel free to jump in if you wanted to, suggest something and make some.
I probably will. I've got so many questions. Yeah. It's just really interesting for me as a behavioural practitioner to try and see, well, what's really driving behaviours of concern. Do you find that as an OT that other behavioural practitioners use this information?
Oh, absolutely. A lot of the times, not just other practitioners, even psychiatrists, people in Royal Children's Hospital, we often, get their phone calls and they'll be like, wow, you did this profile. Can you give us a bit of a sensory support plan because we're having challenges? You worked with them. And then that little green sheet that I showed you, we just, send that over to them. They have, like in bigger hospital units, they've got amazing sensory support rooms. They've got these sensory corners where then they, sort of change the environment to match this person's need and transfer them there. And they do see a big difference much quicker. So absolutely, it is so key. It's unfortunate that NDIS does not acknowledge a lot of sensory related challenges, but it is absolutely something that everybody uses. I can see Erin's raised her hand.
Hey, Nav. I'm just wondering with NDIS, should we be requesting the sensory profiles and things like that on the RFS, or do you kind of decide that that person might need them as well, or just because, we as support coordinators may not know if that person needs one or not, so.
Yep. Oh, that's such a good question, Erin, because, and my response is going to be very funny because a lot of times, when you request this to the NDIS planners, they will put it in their NDIS plan that, this much funding for the OT or, whoever to do a sensory assessment and make sensory recommendations and then purchase assistive technology. So the answer to your question is yes, we can ask the planner, they would do it. Many times we see with NDIS plans who've already come with those recommendations. Now, surprisingly, sometimes, Erin, and this, like my very recent experience, I was in a big care team meeting. The NDIS planner was in it for a very complex participant. And I was, and the Ballarat Health Service Hospital was also online. We were chatting about this participant. And I said, well, we can do this from a sensory perspective. And Ballarat Mental Health Unit said they don't have a sensory room, but they're happy to trial something because they believed in that concept. The NDIS planner sent me a private message on Teams and said, I appreciate what you're talking, but I hope you know that NDIS does not acknowledge or accept anything that is sensory. So, it's a mixed bag. Some planners are very proactive. They do accept it. They do put it in the plans. But then you've got some planners who go by, a very different set of rules. And I think that's just the NDIS for us.
Yeah, definitely. Thank you.
Pleasure. Anyone else? Any questions?
Should be heaps now. I'm just going to fill up the space, yeah?
That's it. That's it.
Mm.
You were asking something, Karen. You said you've got more questions. Go ahead if you wanted to.
So it was regarding the NGIS and I guess the reluctance that they have for acknowledging sensory issues. But from a behavioural practitioner perspective, a lot of our very, very complex clients are almost always very driven by sensory avoidance and sensory seeking. And it confuses me a little bit around how we could silo the sensory side and only consider communication, or where the behaviours of concern are based on communication, excluding sensory. It doesn't make a lot of sense.
Yes, it absolutely doesn't. And that's where I think I really believe it's, because the scheme is so new and they were, I mean, 2013 is when they, made the act, they created everything. It took up until 2017 or 18 to fully roll over in our state. So it's still such a new scheme. And I think they're still learning, they're still evolving. As clinicians, we have to follow best, clinical evidence that we've got, best practice model. And again, if we've got evidence behind what we're doing, we should really push for it, because who else is going to advocate for our patients? Okay. The support coordinators, the clinicians, the behavior practitioners, I think we all, support workers, allied health assistants, I think we all come together, because we are the voice for our patients. And if we do see something and we do raise it, as I said, many times it will come in their NDIS plan written down that, this is what it should be done. Yeah, funding for OT, funding for psychologists to work around sensory issues. So it's a mixed bag, I think.
I had a question about sensory assessments. Like when we do our comprehensive plans and we have to do functional behavioural assessments every 12 months, is that the same sort of time frame for sensory, or is it a more long term?
It depends really. Like a lot of times, Karen, if we do, if we do it in the beginning, it's amazing because, a lot of the sensory needs change based on environmental, even seasons sometimes. It fluctuates. So it's always good to, do it at the beginning so that it marries well, tailors well with the behavior support practitioners or other practitioners, what they're working on. And then the capacity is really there to improve participants' success towards their goal. I would always say to do it in the beginning is great. And then towards the end, if we say, well, because of the sensory measures and because of this disorder's specific needs, that we were able to be met much earlier, during the plan period, this person's got this outcome. Now, if there is good progress, NDIS couldn't care less because they know it's value for money, it's reasonable and necessary, and it reduces care burden over longevity of time. So, I would say to do it in the beginning and then to capture it again as to how much having this evidence-based information and strategies in place reduce that child or person's, needs and longevity.
Yeah, absolutely. So you would, the ratio of, OTs writing SIL and STA recommendations, would that always include the sensory profile?
It depends, Karen. If a lot of times the pressure that clinicians have these days to do SDA and SIL assessments, It's like, well, we need it in 2 months, and they are so comprehensive. There are so many standardized tools that the NDIS needs that often while we're assessing those things, their care and need scales, their general activities of daily assessment, their ABAS, their VODAS, we don't actually see, because it's an observation based, often when you observe a person more regularly, you would be able to see, there's a sensory processing component to his issue that, that moment of awe doesn't happen a lot because it's very quick. It's to get the access, it's to get this, it's to get that. And I really hope in longevity of the scheme that that pressure eases off so that people can actually do a more in-depth and spend so much more time with the participant to finish the work rather than just write reports. Like literally a lot of the times as clinicians, we're just writing
reports. Yeah. Writing reports and not getting the opportunity to actually implement them and then to see whether they're successful or not. I'll probably ask one more question and then leave it open to other people. Are you finding that education department, just from your perspective, are more accepting now of offering sensory tools?
Absolutely. So as one more role that I have is where I do work directly with Department of Education, supporting one of their schemes. And they're very open to the concept. They're very open to the idea. And I think it's purely because they've seen big changes. And, if the kids are doing well, the teachers are happy, principals are happy, the school doesn't need a lot of funding from Department of Ed for ESOs and other things. So everyone's happy. So absolutely, Department of Education is very, very accepting and is proactively absorbing information that we provide.
It's excellent. It's good.
Yeah.
Good. Any other questions apart from me?
Feel free, guys, whatever comes to your mind.
Maybe you've just done such a good job now that there's no questions.
Oh, no, I'm sure there isn't, but thanks, Karen. Janelle, I'm just going to put you on spot there. In your experience working across Hoshin, what has your feedback been? Have you come across a lot of people who've got these challenges?
Thanks, Nav. I'm not going to show my face. Hi, everyone who is here that knows me. Yeah, look, I agree with everything you've said. You can't see my face, but I was shaking or nodding my head with pretty much everything. I guess I'm on the very sort of new to sensory. I guess even acknowledgement, because I work with adults, and it is a very I guess challenging spaces. There's obviously a lot of things that could be helped by sensory input, but it's about what you talked about, the time frames, the reports, the trying to mesh everything in together. And also, Karen, as you mentioned, the ability to actually follow up on what we've recommended and actually be able to work with people to, to have that input. So I'm finding it, I'm quite new to this space. I'm finding it, it's an ongoing challenge, and you've got to basically pick what the most important, prioritize the most important thing. I've got now so many ideas about, I guess, who the sensory needs of the people that I see and how that can be helped, but I've also come up across the blanket NDIS, no, we won't fund sensory, or recognize sensory. So yeah, I don't know if that answers your question. I just, yeah, thank you.
So thanks, Janelle. No, you absolutely did. And I think, because we've got a big team of support coordinators with us too, I really feel like putting it out there that as therapists, we really believe in all the sensory tools that kids need. Often we do know that NDIS will come back while they're auditing and they'll be like, well, you got this product, it's a sensory thing. Haven't you seen our website? We don't fund sensory things, so you got to pay us back, and it was wrongly prescribed. So the answer to that is there's always different ways we can target. So for example, let's say if we know that a child needs a mini trampoline, just because he's always jumping from furniture to furniture, damaging property, has really driving his parents crazy. They've got poor capacity because of this challenge. They're not able to, support their child better. And NDIS is like, nah, we don't fund trampolines, it's a sensory thing. There are many ways. So talk to your clinician around this. I would target it with core muscles. Like if the child's got poor muscle strength, they're not able to sit appropriately, do that long-term writing, they're not able to perform all their gross motor activities, we can use that trampoline as an activity exercise tool as well, where they use it for their gross motor functions, they use it for their core muscle strength, so that their posture gets better, they can better eye-hand coordination. Tie them up with some other goals, and don't mention anything that has to do with sensory, but it does target the sensory component of their care needs too. So if you ever come across NDIS being a little troublesome and saying, no, we're not going to do this, that's this, there's always ways around that, we can get creative and provide the necessary things that our patients need. Fantastic. Any other questions, guys, that comes to your mind?
No.
I haven't got any questions, but I just want to thank you, Nat. That was really good. And thank you. Yeah, I think just what you pointed out about the issues with NDIS planners and getting a planner that has a little bit more insight into the benefits of having the sensory equipment is key. But you can't pick the you can't.
No.
Unfortunately.
Yeah, I think from my perspective too, quite often these sensory tools and the trampoline that you mentioned, Nav, I've got so many young people and a couple of older people who have the ADHD and the autism and behaviours of concern around not being able to meet their sensory needs. Things like that can be actually invaluable if we can redirect someone to bouncing on a trampoline rather than, smashing windows. There's always, yeah, and I think it's such an important thing to consider. I know from my perspective, and even from people who we consider neurotypical, everything that we do every day is sensation based. We can't get away from it, even when we're sleeping. So to have an awareness, and thank you so much, Nav, for today. It was just really invaluable to have the awareness of how to read these reports, why we need them. I know that you probably get sick of me asking for them, so I apologize for that. Because, yeah, I just really like to know what's driving behaviours. So
that's it. And even with the adult population, like as I mentioned, my experience where the planner sort of didn't mention anything in front of the psychiatrist, the whole Ballarat mental health unit, but then messaged me on Teams. My reply was, sure, I will not focus on sensory, but as a clinician, I've got duty of care. I'm not just going to word everything so that I am still targeting their sensory needs, but now I'm just going to word it that it's targeted to the original diagnosis for what that person gained access to the NDIS. So that's what the the planner told me. Well, they've got access to the NDIS only for autism. So everything else that's mental health related, if there's schizophrenia, depression, none of our business. Mental health care, Medicare needs to take care of that. We're not taking care of that. So I was very happy she told that to me, because I will target everything, because you can't isolate and say, well, this behavior was for depression, this behavior was from autism. It's impossible. No one in the world can do it. So I'm just going to make everything sound like, because of the autism related disability, this is what happened, that is what happened, and just provide strategies for that. So in a way, the planner helped me. But, if ever you guys hear a planner say no, don't take it. There are ways around it.
Excellent. So any other questions with our last 4 minutes? I'm sure people will think when they walk away.
Absolutely.
Yeah. I really, really appreciate today. And so this will be recorded, as I mentioned. Nav's going to send me the link to his YouTube channel. I'll post that on all my socials and LinkedIn, and I'm sure Nav, you'll do the same.
Easy done. Yes, absolutely. I will, Karen. And thank you so much for, huddling up together, giving me that call in January and saying we should start something like this, so that, we can better enhance quality of care across our region. And that brings me a lot of joy and happiness, because, we're doing so good. I do, for a lot of people who don't know, I do practice in Melbourne too. And I always say this to my country counterparts, that the quality of care and service that I see in Horsham, Ararat, Wimmera, the Pyrenees region, is something that I don't see even in Melbourne. So we're all doing really good, and we need to be proud of that.
Absolutely, absolutely. So going forward, we'd like to run these sessions maybe every 3 months. So if anyone has any suggestions, I'd really like to get maybe physio and a speech therapist. Got another idea for you, Nav, to do another presentation. I also have on my team a specialist disability sexual health educator, who I'd really like to do a presentation around that. So yeah, any ideas, just drop us an email.
Easy done. And I think, Karen, since Janelle's here, we should target Janelle too. Brings a lot of expertise from Horsham, and it'd be wonderful to get some of her 2 cents too.
Absolutely, Janelle, you're in the hot seat.
Thanks, Nav. You could not see my face laughing a lot then.
No.
Thank you. Yes.
All right. Yeah. Awesome. All right. Well, thanks, everyone. I will stop the recording now. And as Karen has said, I'll upload it onto YouTube, and then we'll share the link with everyone. Thank you for your time today. See you.
Thanks, Nav.